Different stages of shock. Shock is divided into following three major stages: non-progressive or compensated shock, progressive shock, or irreversible shock or refractory shock. Non-progressive shock. It is a stage from which the normal circulatory compensatory mechanism will eventually cause full recovery without help from outside therapy. Whereas progressive shock, in this stage, the shock becomes steadily worse until death. It is reversible with outside therapy. Whereas irreversible shock, where the shock has progressed to such an extent that all forms of known therapy are inadequate to save the person's life. If not properly treated during second stage, the person goes into this stage. If it becomes severe, cardiovascular tissues deteriorate. Refractory shock is the manifestation of late effects of sympathetic vasoconstriction, long sustained decrease of regional circulation, and operation of positive feedback mechanisms. The main causes which precipitate refractory shock leading to death are: there is a cardiac failure and fall in the blood pressure and tachycardia, which leads to decreased coronary flow, myocardial depression, decreased cardiac output, decreases the heart rate, and decreases in coronary blood flow, and which leads to myocardial depression, which can act as a by positive feedback mechanism. Vasomotor failure during initial stages of shock. Vasomotor center is activated during the initial stage. If the abnormality is not corrected during the second stage, it will cause depression of the vasomotor center. Depression of the vasomotor center leads to decrease in vasomotor center activity. There will be fall in both systolic as well as diastolic, and the blood flow to the vasomotor center further decreases. That causes progressive reduction in the blood pressure. Finally, vasomotor center fails. The sluggish circulation, it leads to blockage of minute vessels. Blood supply to the tissues are affected. There will be accumulation of the lactic acid, carbonic acid, that leads to severe acidosis that depresses the activities of myocardium, vasomotor and other tissues, vasomotor center and the other tissues. Acute respiratory distress syndrome, which is seen in septic and severe hypovolemic shock. It is due to the hypoxic and accumulation of H+ ions. There is a damage to alveolar epithelium and endothelium and exudation of fluid into the interstitial space. Compensatory mechanism. It is divided into two groups, so it can be short-term mechanisms or long-term mechanisms. In short-term mechanisms, baroreceptor reflex, chemoreceptor reflex, CNS ischemic response, they play important role. Baroreceptor reflex we have already studied, and chemoreceptor, where there will be loss of blood, causes anemia and stagnant hypoxia. It stimulates the chemoreceptors reflex activities and activates vasomotor center, wherein CNS ischemic reflex, blood pressure less than 30 millimeter of mercury, it is directly going to stimulate the vasomotor center. Then there can be activation of renin-angiotensin system and formation of angiotensin II, which is going to be increased. Angiotensin II acts on subpharyngeal organ which contain an osmoreceptor that increases the thirst. Increased sympathetic activity, it leads to generalized vasoconstriction except in the brain and heart. In brain and heart, so there is vasodilatation because of the presence of beta 2 receptors. Venoconstriction, increased venous return, stroke volume increases and cardiac output increases. And the intense constriction of the splenic vessel lead to the redistribution of the blood to the vital organs, and increases in the activity of reticular activating system, These increase the muscle and thoracic pumping, which are going to increase the venous rhythm, which increase the cardiac output, increase the blood pressure. Increased ACTH and aldosterone secretion causes salt retention, salt and water retention, and cause increase in the blood volume. In kidneys, there is a constriction of the efferent and afferent arterioles. GFR is decreased and prevents renal failure. So these are some of the short-term mechanisms. The long-term mechanisms are, they continues to act for hours to day, sometimes to weeks. So these include, there will be increase in the thirst for the salt, increase in the water absorption from the renal tubules and water absorption from the GIT, conservation of salt and water by kidneys mediated by hormones. After moderate hemorrhage, the circulating plasma volume is restored within 12 to 17 hours. And preformed albumin enters the circulation from the extravascular store to increase the extracellular fluid volume. Increased hepatic synthesis of albumin and other plasma proteins occurs in a period of 3 to 4 days. Increased formation of RBC, that is, formation of RBCs increases, reaches the peak in 10 days, and RBC content restored to normal level by 4 to 48 weeks. There is also increase in 2,3-DPG content shifts the oxygen dissociation curve to the right side. It decreases the affinity of hemoglobin for oxygen. So the more oxygen is released,